Thank you, Professor Gupta, for joining us and to answer some of our many patient questions. Just as by introduction, Professor Diraj Gupta from Liverpool Heart and Chest Hospital, who is also a member of the AF Association Medical Advisory Committee. Thank you.
You're welcome. It's always nice to be chatting with you.
How do you decide which patients are suitable for cardioversion or an ablation?
Okay, well, I suspect it depends on where you are, which cardiologist you see, and whether you are assessed by a specialist electrophysiologist in a tertiary center or by a general cardiologist in a secondary center. Because clearly, a general cardiologist will not be able to offer you catheter ablation, certainly first up. First of all, the most important decision you have to take when you see a patient with atrial fibrillation is whether or not you need to follow a strategy of rhythm control. So if someone is really symptomatic with atrial fibrillation and you've tried them with rate control medications, then you should be offering them rhythm control. Now, rhythm control can take the form of either electrical cardioversion or catheter ablation. Sometimes it could be cardioversion followed by catheter ablation. The important distinction between these two is that catheter ablation is much more likely to be a lasting treatment. Cardioversion, we know, is not likely to last a long time. It could get you a few weeks of sinus rhythm. If you're lucky, especially with medication, it might get you a few months of sinus rhythm. But by and large, most patients who've had cardioversion will tend to flip back into atrial fibrillation. Catheter ablation, you would hope, is more lasting as a treatment compared to cardioversion. We often use cardioversion as a stopgap measure while patients are awaiting catheter ablation. For example, if the waiting list is 6 months, the patient is really symptomatic, we will cardiovert them, and that way they maintain sinus rhythm with medications, and then they can have catheter ablation.
And how many cardioversions could they have, and how many ablations could they have if they're not successful first time?
There is no limit as such. Well, in terms of catheter ablation, usually if you're still in atrial fibrillation after your electrophysiologist has had 2 or maximum 3 goes at ablating your atrial fibrillation, then chances are you are unlikely to benefit from any further attempts at catheter ablation. So certainly in my practice, I would consider very carefully the need for offering somebody a 3rd procedure. So if they haven't yet gone back to normal rhythm after 2 procedures, or they haven't gone from atrial fibrillation to atrial flutter, for example, so if I haven't seen any sign of progress after 2 ablations, then I would be reluctant to offer them a 3rd. Other cardiologists might feel predisposed to offer them a 3rd procedure. But as I said, if you still have an atrial fibrillation after 3 procedures, then you're probably not going to do very well with catheter ablation. With cardioversion, you really ought to be thinking earlier on in the decision-making process. If you had a cardioversion, patients gone back to atrial fibrillation, you could repeat the cardioversion with a drug such as amiodarone, just to see if that improves the chance of you maintaining normal rhythm. Once your AF has come back after a 2nd cardioversion, then you need to stop and think. Either you accept atrial fibrillation if the patient's symptoms are mild, or if the patient's symptoms are severe, you then need to escalate it and refer to a specialist for catheter ablation.
And if both ablation and cardioversion fail, what more can be done?
Okay, well, hopefully in today's day and age, that will be a minority of patients. I would say 80 to 90% of patients in whom catheter ablation is chosen would have a good result from catheter ablation. They may not be cured of atrial fibrillation, but they would have a significant reduction in their AF burden over time. So if you're talking about the minority of patients, 10 or 20% of patients in whom repeated catheter ablation have failed, well, then the options are relatively limited. One could be you accept atrial fibrillation and just follow a strategy of rate control. The other could be you try drug therapy. So we have seen that drugs such as flecainide or amiodarone, which were earlier ineffective before catheter ablation, now are very effective with catheter ablation. So I have a minority of my patients who've had catheter ablation and now are well maintained on low-dose flecainide, who in the past were completely unresponsive to flecainide. So that could be another option. In a very small minority of patients, we could consider them for surgical MACE, so a full-fledged surgical ablation, which is a much more extensive ablation procedure than that's possible with catheter ablation. And that clearly comes with a much more risk because it's an invasive procedure. So I would like to emphasize that's for a minority of patients.
Thank you.
And again, if your rhythm control strategy fails, then you could fall back on the palliative ablatant pace as well. So you could give them a pacemaker and then perform AV node ablation. So they'll still be left with atrial fibrillation, but hopefully they won't have quite so many symptoms from atrial fibrillation.
So there is hope. If cardioversion and ablation don't work, there is still hope that there's something.
Absolutely. Absolutely. There's, as I said, there's, in today's day and age, with the number of treatments available for the patients, it's only a small minority of patients where everything fails.
That's good news. One final question, please, Professor Gupta. Could you just, you mentioned atrial flutter. Could you just explain the difference between atrial fibrillation and atrial flutter? Okay.
To put it simply, atrial flutter is a regular arrhythmia. So atrial fibrillation is a completely irregular or chaotic arrhythmia. Atrial flutter is a much more organized arrhythmia in which your atria, the top chambers of the heart, tend to go along in one dominant circuit. How does that matter to the patient? First of all, it's important to say that in terms of your risk of stroke, both the arrhythmias are identical. So if your doctor has started you on a oral anticoagulant, then it doesn't matter whether you've got flutter or fibrillation, you ought to be taking it because your risk of stroke is likely to be high in either scenario. But the important distinction is in terms of the success rates with catheter ablation. The success rates with catheter ablation for atrial flutter are much higher than those for atrial fibrillation, and the procedure is very often much more straightforward. In fact, it's so straightforward that for atrial flutter, for typical atrial flutter, catheter ablation is now recommended as the first-line treatment rather than medications. Patients should just come in and have a catheter ablation procedure because they're much more, the ablation procedure is likely to work in 95% of the cases, if not higher. And very often it takes an hour or so, a patient will go home the same day. Whereas for atrial fibrillation, ablation is a slightly more complex procedure. Patients often have to stay overnight still. The risks are slightly higher. And so the threshold for offering catheter ablation is a bit higher than for flutter.
Thank you so much. I know that will bring a lot of comfort to patients to better understand the treatment options. And thank you for all that you do for atrial fibrillation patients.
You're welcome. And thanks very much for having me. It's a pleasure. Thank you.